Okay, so today I am going to continue my discussion reading on Graves' disease from the book Robbins. And I'm Dr. Wolf, I'm a pathologist, and I am reading for the basic pathology book that we use in medical school. And so this book, if you didn't see the first video, you should probably go watch the first video. And I explain a little more about why I'm doing this. But let's continue because today we're going to talk about morphology, which means what does it actually look like, with your eyes and also under the scope, and the clinical course. Now, in the book, it's the morphology is the next section, but I'm actually going to switch to the clinical course next, and then we'll look at the actual pathology toward the end, and I will show a couple of pictures. They're really not gruesome at all. One is a macroscopic image of the thyroid and the other is a microscopic image. So let's talk about clinical course. The clinical findings in Graves' disease include changes referable to thyrotoxicosis, as well as those associated uniquely with Graves' disease, diffuse hyperplasia of the thyroid, ophthalmopathy, and dermopathy. Okay, so we're going to go to each one of those terms and define what those are. The degree of thyrotoxicosis varies from case to case and is sometimes less conspicuous than other manifestations of the disease. So when it says thyrotoxicosis, that is actually referring to the increase in thyroid hormone in the body, which causes the symptoms that we talked about in the very first part of the last video. Diffuse enlargement of the thyroid is present in all cases. So diffuse meaning all parts of. Diffuse enlargement of the thyroid. So in other words, it's the opposite of that would be asymmetric or focal enlargement. So in other words, it would just be part of the thyroid. In Graves' disease, it's diffuse or the entire thyroid. The thyroid enlargement may be accompanied by increased flow of blood through the hyperactive gland, often producing an audible bruit. Okay, and that word bruit, that is a uniquely medical word that we don't really use outside of, I've never seen it used outside of medicine. And it's spelt bruit, B-R-U-I-T. So if you want to look up more on bruit, you can. But what a bruit is when a physician can actually listen to the blood flow in the neck, in the carotid artery, and they'll hear a whooshing. Very often, bruits are heard in individuals who have atherosclerosis in their carotid arteries. But in this case, it's saying the increased blood flow to the thyroid is what is creating the bruit. So that's an interesting symptom. Sympathetic overactivity produces a characteristic wide staring gaze and lid lag. So sympathetic overactivity refers to the sympathetic nervous system. That's the one that's kind of the fight or flight part of your nervous system action. The ophthalmopathy of Graves' disease results in abnormal protrusion of the eyeball, also known as exophthalmos, which we talked about in the last video. The extraocular muscles are often weak. The exophthalmos may persist or progress despite successful treatment of the thyrotoxicosis, sometimes resulting in corneal injury or injury to the cornea. And so basically what it's saying is the eyes continue to bulge, and since you're not getting as much protection of the eye, because some folks have deep set eyes, some folks are not quite as deep set. These eyes are protruding, so they're more susceptible to injury. The infiltrative dermopathy, or pretibial myxedema, is most common in the skin overlying the shins, and we talked about that in the last video, where it presents as a scaly thickening and induration. Induration is kind of another word for swelling. However, it is only present in a minority of patients. Sometimes individuals spontaneously develop thyroid hypofunction. So in other words, like hypothyroidism. Patients are at increased risk for other autoimmune diseases, such as systemic lupus erythematosus, or just lupus, pernicious anemia, type 1 diabetes, and Addison's disease, which is a disease of the adrenal gland. Laboratory findings in Graves' disease include elevated free T4 and T3 levels. Those are the thyroid hormone levels that are active in our body, and depressed TSH levels. And again, TSH is the hormone that comes from the pituitary and activates the thyroid. Because of ongoing stimulation of the thyroid follicles by thyroid-stimulating immunoglobulins, radioactive iodine uptake is increased, and radioiodine scans show a diffuse uptake of iodine. So iodine is an element that is concentrated by your thyroid. So if you put iodine in the body, it finds its way to the thyroid. So they can put a radioactive iodine into your system, which then can light up the thyroid gland, and it gives the radiologist and the clinician an idea of how much activity is occurring in that area. So how is Graves' disease treated? Now, as a pathologist, I am not involved with the treatment of the patient. This will be more for your internal medicine doctor, family doctor, endocrinologist who might be treating this disease. Graves' disease is treated with beta blockers, which address the symptoms related to increased beta adrenergic tone. And that is a phrase that corresponds to tachycardia, which is increased heart rate, palpitations, which we know is an increased sensation of the heartbeat, tremulousness or shaking, and anxiety. So all of that can be related to increased activity or of the epinephrine or norepinephrine in your body. Thyroid hormone can also give those type of symptoms. But the beta blocker, like metoprolol or propranolol, those are very common drugs that are they're used for beta blocker. Very versatile drugs for these symptoms. Basically, they are blocking the receptor, the actual receptor for epinephrine or norepinephrine, which then decreases those symptoms. And then also, the other method is by decreasing thyroid hormone synthesis with administration of thionamides. So that is going to be more of a treatment question for your physician if you're watching this from a patient perspective. Radioiodine ablation and surgical intervention. So in other words, when we talk about radioiodine ablation, we're talking about putting radioactive iodine into the body, which then goes to the thyroid, and it will actually, ablation means to destroy. So it'll decrease the activity in that way. And then surgical intervention could involve removal of the thyroid itself and then replacement with thyroid hormone. So that is the end of the clinical section here. And now we're going to switch over and we're going to talk about morphology. And that's really where the pathology element comes in here. All right, so morphology, that means the shape of something or how something looks. The thyroid gland is usually symmetrically enlarged because of diffuse hypertrophy and hyperplasia of thyroid follicle epithelial cells. So let's talk about those terms. Diffuse, again, meaning the entire gland. Hypertrophy means increased size of those follicles. And hyperplasia actually means increased number of those follicles. Increases in weight to over 80 grams are not uncommon. Now, I'll tell you, as a pathologist who does autopsies, you really don't weigh the thyroid. We don't really weigh the thyroid during most of our autopsies unless it is obviously enlarged. On cut section, the parenchyma has a soft, meaty appearance resembling normal muscle. And again, remember, the thyroid is not made of muscle. So it typically has kind of an orangey color to the follicles. When you cut the thyroid, it's kind of an orangey color. But this is saying it looks more meaty, so it's like deeper and red in color. Histologically, meaning under the microscope, the follicular epithelial cells in untreated cases are tall and more crowded than usual. This crowding often results in the formation of small papillae, which project into the follicular lumen and encroach on the colloid, sometimes filling the follicles. So what that's saying is that when you look at it, you can see a papilla is something that's kind of shaped like this. It's like a finger-like projection into the follicle, okay? Such papillae lack fibrovascular cores, in contrast to those of papillary carcinoma. So papillary carcinoma is the most common type of cancer you see in the thyroid, and fibrovascular cores simply mean that there is a good structure of blood vessel and connective tissue within that finger-like projection. The colloid within the follicular lumen is pale with scalloped margins. So colloid is this amorphous material inside of the follicles, and we're going to see a picture of that in just a moment. And it's pale, it's not as dark pink, okay, because it's usually kind of a pinkish color in H&E stain. And then the edge is what is called scalloped, it's kind of cut out, and we're going to look at that in just a moment. Lymphoid infiltrates consisting predominantly of T cells with fewer B cells and mature plasma cells are present throughout the interstitium. Germinal centers are common. So the interstitium is a term for the area between the cells, and a germinal center is the functional part of the lymphoid follicle, or like you can imagine, these are actually in lymph nodes normally, but they're forming because of the increased number of lymphocytes in these thyroids. They're forming germinal centers. Preoperative therapy alters the morphology of the thyroid in Graves' disease. Preoperative administration of iodine causes involution of the epithelium and the accumulation of colloid by blocking thyroglobulin secretion. Involution means kind of something that involutes goes away. And it's blocking thyroglobulin, which is a protein, secretion. Treatment with the anti-thyroid drug propylthiouracil exaggerates the epithelial hypertrophy and hyperplasia by stimulating TSH secretion. So again, hypertrophy means enlargement, hyperplasia means there's more of something. And that's due to TSH, the thyroid hormone, which activates the thyroid to release T3 and T4. Thus, in pre-treated patients, it is impossible from histologic examination of surgical specimens to evaluate the functional activity of the gland. So that's just another way of saying that we can look at it under the microscope and we can't really make a guess as to what the functionality is based on how it looks. Changes in extrathyroidal tissue include generalized lymphoid hyperplasia. So extrathyroidal tissue means the tissue outside of the thyroid. And lymphoid hyperplasia means that you have lymphocyte cells which are increased in number. The heart may be hypertrophied and ischemic changes may be present, particularly in patients with pre-existing coronary artery disease. So the heart may be hypertrophied because you have to remember that thyroid hormone is ramping up the system. And so the heart may be beating faster, it may be beating harder. The person may have hypertension, which can increase the size of the heart. And ischemic changes, it's saying if the person has coronary artery disease, because as you do all those things that I just described, you decrease the blood flow to the heart, which then produces an ischemic change, which means lack of blood flow. It's kind of ischemic change is going the direction of heart attack. In patients with the ophthalmopathy, the tissues of the orbits are edematous because of the presence of hydrophilic mucopolysaccharides. So what does that mean? So the tissues of the orbit, let's break it down, are edematous, meaning swollen because of hydrophilic mucopolysaccharides. So hydrophilic means water-loving. So these are ones that the mucopolysaccharides is the material in and around the eye, which causes that protrusion of the eye. In addition, there is infiltration by lymphocytes and fibrosis. Fibrosis is just another word for scar. Orbital muscles are edematous initially, but may undergo fibrosis late in the course of the disease. The dermopathy, if present, is characterized by thickening of the dermis, that's the area just below the epidermis or the surface of the skin, due to deposition of glycosaminoglycans and lymphocyte infiltration. I'm not really going to go into glycosaminoglycans. That's an entire biochemistry lesson in its own. It's more important to just, first of all, know that if you're a medical student for your tests, but it's basically saying that you're getting a deposition, or it's putting stuff down inside of that dermis, which is what's causing the thickening or that pretibial edema. Now, with all of that being read from the first video to the last video, let's now look at Graves' disease, the pictures here in Robbins. Okay, so this is a Graves' disease thyroid. So you can imagine that it does have that butterfly shape that the normal thyroid has, but notice how expanded these are. These are thick and expanded. So this is like one lobe of the thyroid, the other lobe of the thyroid, and then there's a little part that sticks up called the isthmus there. And you can kind of see some vague nodularity throughout. So this is kind of an enlarged, thick-looking thyroid. They tend to be a little more well-defined, and that's because this is that hyperplasia and hypertrophy that we talked about. So the hyperplasia, meaning there are increased numbers of follicles, and we'll see that in the next image, and then the hypertrophy, which makes each follicle larger. Now, if we go over here, this is the actual microscopic examination here. And these are those follicles that we talked about. And they're usually more rounded, and they're filled with this material we call colloid. And then remember when we talked about earlier in the earlier part of the reading that the edges are scalloped. So you see, if you look closely there, let's get in a little bit closer here. You can see scalloping at the edges. That's that white area. Well, in normal thyroids, you don't see scalloping. It goes right to the edge of the follicle. So the shape is different here. You get the scalloping, which is a really good hint for me that hyperthyroidism is occurring when I look at thyroids under the microscope. And then you can see in the background here, there's increased numbers of these fibrovascular cores. Remember when we talked about the papillae? This is what we're talking about, a finger-like projection into the follicle itself. Okay, we're done with Graves' disease now, reasonably low quality production there, but I wanted to kind of do that as a test run to see if this is something that people are interested in for me to teach directly from the book about disease X or disease Y. And, we'll gradually get things a little more higher quality. But what this does is this covers everything you could need to know about Graves' disease from the pathology perspective. And as I always say, pathology is the key to medicine. If you understand why something is abnormal, then you understand how to treat that disease. So this is for medical students who might be interested in hearing a pathologist's perspective, and also for patients who are on YouTube and they just want to learn more about Graves' disease. This has been kind of a long thing, maybe, almost 30 minutes or more of reading and talking about Graves' disease, but it is possible that that's more than you will get in your appointment when you go to get treatment for it, and typically you won't get this much pathology information, so I hope this has been useful.